So today we will discuss about short notes on DKA, that is diabetic ketoacidosis. Ketoacidosis. Okay. So before discussing this, we will shortly discuss about the physiology involved in this. So normally DKA usually presents in type 1 diabetes patients, and of course in type 2 also you will see the DKA picture. So what happens inside the body is like, uh, suppose in type 1 diabetes there will be very less insulin. So what is the function of insulin? Insulin causes glucose to enter the cells, so that cells will utilize the glucose. So now what happens, as there is a very less insulin, as there is very less insulin, there will be action of counter regulatory hormones. So these hormones are such as glucagon, epinephrine, cortisol, and growth hormones, for example. So what these hormones will do is, like, for example, in liver there will be glycogen. The glycogen will gets converted into glucose, and proteins and lipids will also get converted into glucose. So this glycogen will get converted into glucose through glucogenolysis, and here gluconeogenesis. Yeah. So what happens is, like, as cells will be starving of glucose, what will happen is that these counter regulatory hormones will initiate this glycogenolysis and gluconeogenesis. What happens? The glucose, high amount of glucose will be released into the blood, and because of this high glucose inside the blood, what happens is, like, the kidneys, normally what kidneys will do, this will reabsorb glucose, so up to certain level. So after some time, kidneys have done this function to reabsorb glucose, and the excess glucose will be excreted out into urine. Yeah, excreted into urine along with electrolytes and obviously water. So that's why patient will be having polyuria, dehydration, and polydipsia. So lot of water patient will get lost. So that's the reason polydipsia will be seen. So, and now what happens, because of this counter regulatory hormone, there will be fat will be converted into fatty acids. So through this is called lipolysis. So these fatty acids are acetone and beta hydroxy butyrate and acetoacetate. So basically these acetone, beta hydroxybutyrate and acetoacetate, these three are acids. So these acids will be in the blood, which will cause metabolic acidosis. So you can see a patient coming with DKA definitely will be having metabolic acidosis. Usually the pH will be less than 7.3, right? And one more important thing is like uh, regarding the potassium. Sometimes the potassium will be high, sometimes the potassium will be low. So what happens is like because of metabolic acidosis, there will be more number of hydrogen ions in the blood, and in order to compensate, these hydrogen ions will be shifted into the cells, and the potassium ions which are inside the cells, that will be shifted back to blood as a compensatory mechanism. So this will be shifted into the cells, hydrogen ions will be shifted into the cells, and the potassium ions will be coming into the blood. Because of this, patients with DKA will be having hyperkalemia, and as there is a excessive diuresis, we talked about polyuria. Because of polyuria, what happens, this potassium ion will get lost into the urine. So that is why we also see hypokalemia, right? And that is the physiology part. Sorry. So now see, always remember, any patient presenting with, most commonly we see patient presenting with abdominal pain. We tend to think that patient is having some constipation or something. So even though some patients are not diagnosed with diabetes, a patient coming with abdominal pain, especially in the young males, always check for sugar. Take an ABG. ABG will show the pH value, the glucose and potassium, everything you can see in the ABG. So the symptoms, once again I will repeat the symptom. Patient will be having excessive thirst and dehydration, polyuria, and there will be abdominal pain, and patient will be having, this is important, shallow breathing. Why the patient will be having shallow breathing? See, the patient is having is in acidotic state. In order to compensate from this situation, the body tries to get rid of this acidotic state in the form of CO2 exhalation. So more amount of CO2 is being exhaled. So this shallow breathing is called Kussmaul breathing. So Kussmaul breathing is also one of the signs which you see in diabetic ketoacidosis, right? So always remember, patient presenting with any infection. Suppose the patient is in sepsis, and for example UTI, respiratory tract infections. Usually DKA is present in the patients having infections. So any patient presenting with sepsis or septic shock, always think about DKA, especially in non-diabetic cases. And one more thing, infarction. And infarction means like it could be stroke, MI, okay, and then in insufficient insulin, as we previously talked about this one, that is type 1 diabetes. There will be insufficient insulin. Okay, right. And now we go to the treatment part. How do you treat this patient? Usually what we do, we have to do not rush for giving insulin. No, insulin cannot be given. That is not our priority. The mainstay of treatment is like we have to flush out these acetone and beta hydroxy butyrate in order to maintain the pH. So what we do, first we give NS 500 ml to 1000 ml in half an hour to 1 hour, first hour. And then what you do, and the second 500 ml in 2 hours, and third 500 ml in 4 hours. Yeah, like that you have to do. And then you have to monitor GRBS hourly. Hourly GRBS monitoring should be done. And we have to be cautious in case of patients like existing cardiac cases, where you can give 200 ml bolus. Yeah. 200 ml bolus, wait for 5 minutes, and then give 200 ml bolus. So these repeated bolus is called aliquots. Yeah. Because if you give more fluid, the patient will end up in pulmonary edema. Fluid overload will be there. Again, it will be a complicated one. And then when you so while you are checking hourly GRBS, so when the sugars are like 250 milligram per deciliter, you should start with 10% glucose at a rate of 125 ml per hour in order to maintain acid base state. And you have to concentrate on this potassium level. So why? Because see, you are starting insulin at a rate of 0.1 unit per kg per hour. So usually in adults in ER we will start with 6 units per hour, and we have the sliding scale. Yeah. So what happens if you give IV insulin? This will cause hypokalemia. So we should always check for potassium levels while we are treating DKA. So suppose if the potassium levels are less than 3.5, you should add 40 millimoles of KCl along with the fluid. And the last thing is consider nasogastric tube. Rails tube you have to put to decrease the gastric dilation and aspiration, because most of the patients will be coming to you in semi-conscious state. Patient will be drowsy, So nasogastric tube is also important, and moreover urine output we have to check for any fluid overload and admit the patient.